Hi everyone, today's topic is examination and diagnosis in operative dentistry procedures, dental radiology in relation to conservative dentistry. So your learning outcomes are interpret patient assessment, identify risk profile, identify prognosis, discuss clinical examination of caries and additional defects, discuss clinical examination of amalgam restorations and composite restorations, outline the principles of radiographs and factors that influence taking of radiographs, categorize the guidelines for prescribing radiographs in endodontics and for caries detection in new or recalled patient, discriminate the radiographic appearance of caries and role of intraoral radiographic views in caries detection and classification, and differentiate extraoral radiograph and their application. So first one is patient assessment. So the general consideration. Clinical examination is the hands-on process of observing the patient's oral structures and detecting the signs, symptoms of abnormal conditions or disease. This information is used to formulate diagnosis, which are a determination or judgment of health versus disease and variations from normal. During the clinical examination, the dentist must be keenly sensitive to subtle signs, symptoms, and variations from normal to detect pathologic conditions and etiologic factors. Meticulous attention to detail generates a base of information for assessing the patient's general physical health and diagnosis specific dental problems. So the success of operative treatment depends heavily on an appropriate plan of care, which in turn is based on a comprehensive analysis of patients' reason for seeking care and on a systematic assessment of patients' current condition and risk for the future problems. So this information is then combined with the best available evidence on the approaches to managing the patient needs so that an appropriate plan of care can be offered to the patient. Infection control before, during, and any after any patient visit. Appropriate infection control measures must be instituted. To provide a professional healthcare atmosphere, barrier technique should be followed strictly. Barrier technique includes the use of gloves, mask, protective eyewear, overgarments, and plastic barriers. Proper use of disinfectants and instrument sterilization to be followed. So for the infection control protocol, you can see it is in e-portal, and during the orientation week you have been trained how to follow the infection control protocol. So please be aware of it and use proper appropriate infection control during the procedures. First one is chief complaint. Before initiating any treatment, it is important to determine the patient chief complaint or the problem that initiated the patient visit. The patient should be encouraged and guided to discuss all aspects of current problems, including onset, duration, symptoms, and related factors. This information is vital to establish the need for specific diagnostic tool or test. So chief complaint is all about patient's problems. So listen to that carefully, gather all the information, and formulate the proper diagnosis with the help of useful tests. Medical review. This helps in identification of any condition that may complicate or contraindicate the proposed dental procedures. The practitioners may identify communicable diseases such as hepatitis, requires special precautions and proper barrier technique to prevent the cross infection, allergies from certain drugs, example penicillin, medications that may contraindicate the dental procedures, and systemic condition or any cardiac problems that needs a prophylactic antibiotic coverage. So through the medical history we can get to these details, and this will help during the treatment which we are going to perform. Dental history. So the dental history consists of reviewing previous dental experience and current dental problems. Past dental history, it gives an indication about patient's motivation of dental care and frequency to dental visit, and so operator can expect future behavior. If a patient has difficulty or problems with certain types of dental procedures, alterations of the treatment or environment may help avoid future complications. Present dental history. The patient present problem, chief complaint should be recorded in the chart. Date and type of available radiograph should be recorded to determine the need for additional radiograph and to minimize the patient exposure to radiation. So from the past dental history, you can understand what the patient has gone through and you can get an idea about the patient. From the present dental history, you can record the chief complaint and followed by the whatever necessary test or the investigations you have done, that should be recorded. Diagnosis of dental caries. So the identification of caries, dental caries is diagnosed by one or all of the following. So first one is visual examination, tactile sensation, and the third one is through radiographs. So the first one is visual examination. It is performed using a mouth mirror only. Visual changes in the tooth structure, texture, or color can be revealed as an actual cavitation, chalky white appearance, discolored fissures, or shadow under marginal ridge, as in case of proximal caries. Tactile sensation is done using mouth mirror and probe. Mirror and probe can be used to detect catches in deep fissures or softness at the base of the fissures. It is recommended to use a blunt probe or explorer with very light pressure to examine the texture of the tooth surface, because sharp probe will damage non-cavited demineralized surface, rendering them unable to remineralize and retain teeth. So with the help of visual and tactile sensation, you can see and find out, and probe, with the help of a probe you can find out whether the caries is there, whichever wherever surface you can find. So that's how you identify the caries, with the help of visual and tactile sensation. International Caries Detection and Assessment System. This was developed developed to serve as a guide for standardized visual caries assessment that could be used for clinical practice, clinical research, education, and epidemiology. So this requires two minimum conditions for examination to be properly conducted. The teeth must be sufficiently hair dried so that the changes can be seen properly, and there should be a thoroughly clean tooth surface so that the examination can be done properly. So it uses a two-stage process to record the status of the caries. The first code for the restorative status of the tooth, and the second for the severity of the caries lesion. So in our clinical case sheet, this ICDAS scoring sheet is incorporated so that individual tooth surface should be checked and that score has to be placed onto the tooth surface. This is the caries severity code for the ICDAS. So first one is 0, that is sound tooth structure. Then 1, that is the first visual change in the enamel. Then comes the 2, that is the distinctive visual change in the enamel. Third, that is 3, that is the enamel breakdown but no visible dentin. Fourth is dentinal dark shadow, so no cavitation into the dentin. Fifth is the distinct cavity with the visible dentin, small opening, and the dentin is visible. Sixth is the extensive distinct cavity with the visible dentin. You can see the big cavity and dentin is exposed. Again, along with the restoration of sealant code and caries code, you can see to 0 to 8. According to that, the restoration of sealant code goes, and 0 to 6, that is the caries code. Coming to the caries risk assessment. Caries risk assessment may be defined as the probability that a specific number of lesions will develop or and specific number of existing lesions will progress over a specific period of time. So the caries risk assessment chart along with the case sheet, this is also attached. How you are going to find out? First you ask to the patient about the contributing condition. That is, first one is fluoride, second one is the sugary foods or drinks, then the dental home, that is the established patient of record receiving regular dental care in the dental office. According to that, you have to mark on the record onto the low risk, moderate risk, or high risk patient. whichever the patient confirms, according to that you can mark. So once the any recording comes into the high risk, patient directly goes to the high risk. If it is low risk, we have to go for the next is Caries assessment according to the general health condition. That's the second part. So first one is special healthcare needs. That is the developmental, physical, medical, or mental disabilities that prevent or limit performance of adequate healthcare by themselves or caregivers. Chemotherapy, radiation and therapy. Third is eating disorder. Fourth is medication that reduce salivary flow. And fifth one is drug or alcohol abuse. So according to the patient feedback, you have to mark yes and no. So the third part of Caries risk assessment is the clinical conditions. The first one is cavitated or non-cavitated or Caries lesions or restorations. So there are no new ones in last 36 months. The patient goes to the low risk. If there are one or two new ones in last 36 months, it is moderate risk. Three or four new ones in last 36 months, then patient belongs to a high risk group. Then the second one is teeth missing due to caries in past 36 months. If there is no teeth missing, then patient goes to the low risk. If there is any missing tooth in last 36 months, then the patient goes to the high risk. Then visible plaque. If there is visible plaque, then patient goes to moderate risk. There is no visible plaque, then patient goes to low risk. Unusual tooth morphology in the proximal restoration one or more. If there is present, then patient goes to moderate risk. If there is no, then patient goes to low risk. Same goes for the exposed root surface restoration with overhangs or open margins or open contact with foot impaction, dental or orthodontic appliances, then severe dry mouth. So if there is any presence of this, then the patient goes to moderate risk. If there is no, then the patient goes to the low risk. So the overall assessment of the caries risk assessment can be decided if there is any recording onto the high risk group, then the patient goes to the high risk. If there is any marking on the moderate, only on the moderate, then goes to the moderate, and everything is on the low, then the patient goes to the low risk. So like that we can decide the caries risk assessment whether the patient belongs to low, moderate or high. Coming to radiographs. Traditional piping radiographs are still mandatory as a diagnostic aid for the caries active patients. IOPA can also be used for identifying caries. The difference is the angulation, which gives you two perspective and helpful in diagnosing recurrent caries. The radiograph should be interpreted with caution, and the speed of the progression of caries should be assessed before the dentist decide to undertake restorative procedures. So when you are not able to see the marginal surfaces or with the help of probe and mirror you are not able to assess the margins, then definitely you have to go for the radiograph. Other conditions you might need to go for might be because if you are not able to assess how deep the cavity or the caries has gone, in that case also you have to, because after probing also you are not able to identify how deep the caries has invaded. So the only way to find out is with the help of an IOPA or bite wings. Bite wings are more commonly used for the proximal restorations, but more commonly we use IOPA so that we can get the caries, how deep is it, and if there is a secondary caries also we can make out easily. So commonly used one is bite wings or IOPs, intraoral periapical radiographs. So the recommendations for prescribing dental radiographs. So these recommendations are subject to clinical judgment and may not apply to every patient. They are used to by dentist only after reviewing the patient's dental history and completing a clinical examination. Even though the radiation exposure from dental radiograph is low, once decision to obtain radiograph is made, it is the dentist's responsibility to follow the ALARA principle as low as reasonably achievable to minimize the patient exposure. So again I am stressing you, whenever the radiograph is required you have to use it, but you have to use the radiograph wisely. If there is a need, then only we should use. Just because there is a caries, no need to take a radiograph. If you are not to do are not able to assess the depth of the cavity or the caries, and definitely proximal lesions sometimes you won't be able to identify with the help of probe. So in that case you have to go ahead with a radiograph. So how to prescribe radiograph for the new patients? So new patients being evaluated for dental caries. So posterior bite wings and or periapical radiographic images can be used. So individualized radiographic exam based on clinical signs and symptoms. Recall patient with clinical caries or at increased risk for caries posterior biting exam at 6 to 12 months interval if proximal surface cannot be examined visually or with a probe. Recall patient with no clinical caries and no at increased risk for caries posterior biting exam at 18 to 36 month intervals. So this is how we manage to take radiographs for patients depends upon their caries risk and new patients. So again I'm stressing you, whenever there is a need then only you will go ahead with the radiograph, especially you are not able to identify the caries with the probe or mouth mirror. So in that cases you have to go for the radiograph, especially the proximal regions you won't be able to identify. So definitely you have to go for a posterior biting or periapical radiographs. Okay, coming back to dental caries. Dental caries is the breakdown of tooth structure caused by acid producing bacteria. The bacteria break down carbohydrate to form acid that demineralize the tooth structure, leading to caries. So the diagnosis of caries is made through a combination of clinical examination and radiographic evaluation. Approximately 40 to 50% demineralization is required for radiographic detection of lesion. So the actual depth of penetration of a caries lesion is actually deeper than it appears onto the radiographs. So the factors affecting the appearance of caries on radiograph: buccal, lingual, thickness of the tooth. The thicker the tooth, the more difficult to see the extent. Limitation of a two-dimensional film. X-ray tube angulation, that is the horizontal or vertical changes. It may change the angulation. Then the exposure factors: lower the kilovoltage peak setting, higher the contrast. So when you judge the IOPS, these factors should be considered to identify the caries. So in the first picture you can see the proximal lesions of the molars. You can see mesial caries and distal caries. Then the second picture you can see the first molar, you can see an occlusal caries. Then the third picture you can see the rampant caries. You have multiple tooth as having caries over the mesial, distal. Same tooth is only having on the both sides, and almost all tooth has caries. Then the last one you can see the down picture. You can see there is a restoration on the first molar, and underneath that there is a secondary caries. So out of this, if you ask me which one is easy to identify without the IOPA, I can say that there is only one thing which you won't be able to see, that is the restoration with secondary caries, the last one. Rest all you will be able to identify the caries. But why you are taking this radiograph? Because you won't be able to judge the depth of the decay. So for example, in the first picture it is almost involving the pulp, maybe the mesial pulp one is already involved. So that is why you need an IOPA to confirm about the treatment planning. First you need to diagnose, then only you can go for the treatment. So in this case you have to go for a root canal therapy that can be decided with the help of radiograph. Second one, you can see that there is no involvement of the pulp horn, so that you can go for the restoration. So that is why you need to take an IOPA and confirm. So it can be really helpful for the diagnosis part. So that's why it is important to, just before going for the diagnosis, you have to confirm with the investigations. Then the last one, that is the restoration secondary caries. Here also it's really close to the pulp. So by taking an IOPA, we can see whether how is the present condition of the tooth. So in this case, you have to go for a deep caries management before, by checking the vitality of the tooth. If the tooth is vital, then you can try for a deep caries management. But if it fails, then you have to go for a root canal therapy. So these are the some examples of radiographs for the caries detection. So two main types of dental X-rays used is intraoral and extraoral. Intraoral meaning the X-ray film used inside the mouth, and extraoral is used outside the mouth. So the intraoral radiographs are the most common type of dental X-ray taken. So these X-rays provide a lot of detail and allow dentists to view cavities, check the health of the tooth root and bones surrounding the tooth, check the status of developing teeth, and monitor the general health of your teeth and jawbone. Extraoral radiographs show the teeth, but their main focus is the jaw and skull. So these X-rays do not provide the detail found with the intraoral X-rays, and therefore are not used for detecting cavities or for identifying problems with the individual teeth. Extraoral radiographs are used for impacted teeth, monitor growth and development of the jaws in relation to the teeth, and to identify potential problem between teeth and jaws and the temporomandibular joint or other bones of the face. So basically, intraoral radiographs are much more commonly used to detect the caries and their prognosis. Basically, you look into the periodontium, the tooth and the attachment. So then how you can decide the treatment plan, whereas extraoral is more towards the growth of the bone, or if there is any big lesion, multiple lesion around the tooth. In that conditions you can use the extraoral radiographs. Coming to radiographic artifacts. So an artifact is a structure or an appearance that is not normally present on the radiograph and is produced by artificial means. So the commonly occurred one is the distorted images. It can be happen due to improper alignment of the tube, object or film. Basically the change in angulation. It can be uh, elongation in the form of vertical, and if there is a foreshortening, if the reduction in the angulation. So distorted images are commonly seen, so because of the improper alignment of the tube, object of the film. Second one is the finger marks. So during the improper handling of the radiograph while developing, it can end up in marking of the finger. Then the blood images. So this happens when there is a movement of patient or film or the tube during the time of exposure. So the image comes as a blood image. So carefully you have to take the IOP or the procedure you have to do carefully. Concord. This is happens because the beam of radiation did not cover the film, so it comes as a blank part on the radiograph. So when you're placing the cone, make sure it go completely covers the radiograph. Then comes the herringbone pattern or tire tag, which is commonly happen if the film is placed on the wrong way and expose it, so that you can say a tire mark onto the developed radiograph. So these are the commonly occurred artifacts onto the radiographic images. Prognosis. The prognosis is a prediction of the probable cause, duration, and outcome of a disease based on general knowledge of the pathogenesis of the disease and the presence of risk factors for the disease. It is established after the diagnosis is made and before the treatment plan is established. The prognosis is based on specific information about the disease and the manner in which it can be treated, but it also can be influenced by the clinician's previous experience with treatment outcomes as they relate to the particular case. It is important to note that the determination of prognosis is a dynamic process. As such, the prognosis initially assigned should be reevaluated after completion of all phases of therapy, including periodontal maintenance. So basically, prognosis is the outcome of disease based on the pathogenesis of the disease and the presence of the risk factor for the same. Prognosis is often confused with the term risk. Risk generally deals with the likelihood that an individual will develop a disease in specified period. Risk factors are those characteristics of an individual that put the person at increased risk for developing a disease. In contrast, prognosis is the prediction of the course or the outcome of a disease. In some cases, risk factors and prognostic factors are same. For example, patients with diabetes or patients who smoke are more at risk for acquiring periodontal disease, and once they have it, they generally have a worse prognosis. Classification of prognosis. Good prognosis, control of etiologic factors, and adequate periodontal support ensure the tooth will be easy to maintain by the patient and clinician. Fair prognosis, approximately 25% of attachment loss and or a class 1 fluctuation involvement. Poor prognosis, 50% of attachment loss and a class 2 fluctuation involvement. Questionable prognosis, more than 50% attachment loss and poor procorum to root ratio, poor root forms and a class 2 furcation. Help hopeless prognosis, inadequate attachment to maintain the health, comfort and function. So basically I have attached the classification of prognosis for your understanding. So most of the time when you talk about the case, the patient might ask you how long the tooth will last. So you can talk about the prognosis of the it has a good prognosis, fair prognosis, poor prognosis or a questionable prognosis. Most of the time hopeless prognosis, it is very difficult to maintain, so you have to go for removal. So that is how it helps. Clinical examination of amalgam and composite restoration. Evaluation of existing restoration should be accomplished systematically in a clean, dry, backlit field. Clinical evaluation of amalgam restoration required visual observation, application of tactile sense with the explorer probes, use of dental floss, interpretation of radiograph, and knowledge of probabilities that a given condition is sound or at the risk of further breakdown. Some of the conditions you may observe during the examination are amalgam blues, proximal overhanging, marginal ridging, etc. So the first one is the amalgam blue. So the bluish hue results from the leaching of amalgam corrosion products into the dentin tubules, as the color of the underlying amalgam is seen through the enamel. It may occur as a result because there is no dentin support, such as undermined cusp, marginal ridges, and regions adjacent to the proximal margin. So there won't be enough dentin so that the shadow comes through the enamel. That is why how it is seen. Then it does not require any restoration. Amalgam blues do not indicate any caries, so no treatment is required. But in terms of aesthetics, if the patient is requesting, it can be done. The restoration can be removed and replaced with a aesthetic restoration. Then the second one is the overhanging. It can be diagnosed visually, tactily and radiographically. So radiographs you can see easily the overhangings. So with the help of a probe you can run from the mesial to distal side, you can find a catch over there. Mostly you can say that it's an overhang. Other way to find out is passing through the, you say, floss, and the floss will tear and come off because of the sharp margins, or it just gets stuck underneath the overhanging. That's how you find out. And of course with the radiograph, so it has to be removed and restored with proper contacts and contour. The first picture you can see the marginal ditching and improper contouring also you can see of amalgam. Second one you can see the same thing on the composite, and there is a secondary caries. And amalgam restoration also occlusal contouring is not good. So the marginal ditching or marginal gap is the deterioration of the restoration tooth interface as a result of wear, fracture or an improper tooth preparation. So it can be diagnosed visually or by the help of a probe or explorer. It might be seen as small opening along the borders of the margin. So the small margin exposure, which is needed to be treated, but the base that is about less than 0.5 mmd is not a reason for restoration. But if it's a big one, it can go into a reason for secondary caries because of the debris and bacteria can accumulate over there and it will hamper the restoration. So it has to be removed and replaced. So this picture you can clearly see the margins are really bad for the composite and restoration. And secondly, about the contouring, when you are doing an restoration, the contours you should be at least try to replicate the lost cusp, so according to the occlusion. So in the amalgam, you can see clearly the palatal surface. It's not contoured properly. You can see the bite marks over there. So contouring is also an important part. So ideally, this restoration has to be removed and replaced with a new one. So especially you can see the secondary caries with the composite on the right side of the picture. So marginal ditching or marginal voids or the marginal gap commonly seen during the clinical examination of amalgam restorations because there might be a improper condensation or preparation of the tooth structure and maybe because of the occlusal loads. Next one, you can see the significant improper contouring here. There is no contouring, flat composite you can see. Then the first picture only, the amalgam restoration, you can see the fracture of the cusp and recurrent caries as well. The second picture you can see it is aesthetically unappealing. Basically there is a old restoration, composite restoration, shade not matching, maybe over a period of time it change. Then the marginal discoloration you can see. So most of the time this happens due to because improper tooth preparation again. Then definitely again contouring has to be reconsidered here because the composite, when you're again when you're doing a restoration, you should at least try to replicate the tooth structure or replicate the tooth form, then only the tooth can function. So, and definitely you have to do proper tooth preparation for amalgam restorations, then only the tooth is going to mechanically lock onto the tooth surface. So it is important to do the tooth preparation very carefully with amalgam preparation because it is mechanically locked onto the tooth surface, whereas composite it is as etched, that is it is nicely bonded to the tooth structure. So at least when you're doing your restoration, try to recreate the occlusal contours and the margins properly so that these problems will not happen. So how to identify? With the help of radiograph you can clearly see the secondary caries with the first picture, and definitely running the probe you can see the soft debris, and definitely there is a leakage of restoration. Definitely you need a re-restoration for the first picture. Second one, aesthetically it is not good, so definitely it's an anterior tooth, nobody likes that way. So when you do your restoration, make sure if there is an unsupported enamel, it has to be beveled properly, then the margin should be sealed properly and it should be polished well. If you do a good polishing, then you can stop this marginal discoloration and or you can avoid it completely, and your preparation should be good enough so that there won't be any exposed margins, and a good shade selection should be done so that it cannot happen in future cases. In the first picture, you can see the line across the occlusal surface of an amalgam restoration that indicates the fracture of the restoration, so that has to be replaced, and the contouring is also not good because the amalgam restoration should uh, replicate or duplicate the normal anatomic contours of the teeth. That might be one of the reason it might be fractured. Then the second restoration, you can see the arrow, it indicates the two restoration placed at separate appointment. So it is fine, might have done a repair work, but again the contours should be replicated properly. So you might see a lot of other uh, conditions, but some of them are these all conditions you can see in a composite and amalgam restorations. So try to, when you are doing clinical evaluation, you have to check for the margins and contours. If it is not done properly, it has to be replaced with a new one. So that's all about today's lecture. Thank you. If any doubts, you can contact me. Thank you.